Are you able to see my screen? Today we are going to discuss another important aspect in managing persons with hearing disability. In our last class, we learnt about how to rehabilitate patients with hearing difficulties using a hearing aid. Now, today we are going to venture into a new technology. Of course, the technology per se, if I say new, it is a laughable statement because this technology has been there for nearly good 15 years. So, let me confess that otolaryngologists have been in the forefront of all the innovations in medicine. I am not joking if I say that. You would have known about various prostheses which has been used, but the first prosthesis, first complete auditory prosthesis happens to be your cochlear implant. I repeat again, the first complete auditory prosthesis happens to be the cochlear implant. Why I say that is, it effectively performs the function of outer ear, middle ear and the inner ear. So, directly this implant is going to communicate or transmit impulses to the auditory nerve. So, it is going to bypass the entire auditory external ear, middle ear and inner ear, and it is directly going to communicate to the auditory nerve. So, this is the first time, this is the first technology which has proved that direct communication with the nerve by a artificial device is possible. So, this is the first time, the standing proof that direct communication is possible between a prosthesis and a nerve. So, this device can be aptly termed as a bionic ear. It is called a bionic ear. So, it is a biological and electronic ear. So, let us go into the concept of cochlear implant. What exactly is a cochlear implant? This is actually a small electronic device, but this is supposed to stimulate the cochlear nerve, and cochlear nerve gets stimulated in response to the sound stimulus which reaches via the electronic device. And let me repeat again and again, this is the first time, in fact, any cranial nerve has been directly stimulated by a electronic device. So, direct stimulation of cranial nerve and making it understand the stimulus is very unique concept. And this cochlear implant per se has two parts. One happens to be the external part. The external part usually seats behind the ear, as we saw in the behind the ear model hearing aid, which we discussed in our last session. So, this is actually more or less in the picture you will be seeing more or less resembles your behind the ear model hearing aid. This component contains a microphone, it has a speech processor, and what happens is, and a transmitting coil. This is the transmitting coil, this is the transmitter. So, this entire unit is the external unit, and of course, the lower portion of this box or a container contains a battery. So, the components of the external part of cochlear implant happens to be the microphone which receives the sound stimulus, then the speech processor which actually breaks down the spoken words into different frequencies, converts it into a digital signal, and then there is a transmitter coil. So, that coil transmits these signals to the transmitter. The entire unit is seated outside the skull. This entire unit, the external unit, is seated outside the skull. On top of it, the lower portion of the process, the external process, contains the battery or the power supply. So, what happens to the inner part? The inner part contains two portions. One happens to be the receiver. This receiver actually receives the digitalized signal from the outer part, and then it transmits these signals via electrodes or array, a series of this small portion of wire, it contains a large number of fine electrodes, 18, 16, 24. The numbers vary according to the generation of cochlear implant. So these wires are pushed into the cochlea. So these wires stimulate the cochlear nerves directly by the impulses which are received by the receiver. How exactly this cochlear implant works? Sound is actually picked up by the microphone which is present in the outer unit, and then this sound is sent to the speech processor via a small connecting cable, and this speech processor has got a unique role to play. It is a filter, auditory filter. It filters the incoming signal into different frequencies, and when it filters and converts these signals, incoming sound signals, into different frequencies, it also digitalizes the analog sound into digital sound. So in other words, it converts the sound energy into electrical energy. So it digitalizes the auditory potential into electrical potential. So the digital signal is sent back to the transmitting coil. So the digital stimulus is sent back to the transmitting coil. And what happens is, this transmitting coil is held in place by presence of a magnet. So there is a magnet there in the outer unit which is holding the outer unit in contact with the unit inside. We will deal with the inner component later. The outer unit and the inner unit are held together by the presence of magnet in the outer unit and the magnet in the inner unit. So the transmitter coil transmits the digitalized information across the skin to the internal receiver. So skin is the only barrier to the transmission of impulses from the outer unit to the inner receiver. The inner receiver, what it does is, on receipt of this signal, it decodes the incoming signal, breaks down the frequency and sends the information to different electrodes within the cochlea. So what happens is, it breaks down the entire signal into different frequencies and transmits it inside the cable. There will be different cable arrays, a collection of cables. So it will be, for example, low frequency, there will be one cable, middle frequency, there will be another cable. So like that, there will be each band of frequency will be having different frequencies. So what happens is, the internal receiver breaks down the incoming signals into different frequency band and sends it across to the auditory nerve via these array of electrodes. For example, high frequency information is sent to the electrodes which end in the basal turn of the cochlea. I repeat again, in your auditory physiology, you would have learnt that high frequency information is processed at the level of basal turn of the cochlea. I repeat again, physiologically, high frequency information is processed at the basal turn of the cochlea. So similarly, the high frequency information which is received by the inner receiver is transmitted to electrodes which end at the basal turn of the cochlea, and the low frequency information is sent to the apical end of the cochlea. So this is how the different frequencies find their way into stimulating different areas of the vestibular cochlear nerve. So these intracochlear electrodes, the array of electrodes, they play the role of cochlea. I repeat again, the intracochlear electrodes which we pass into the cochlea play the role of the cochlear structures like hair cells. So the auditory nerve actually picks up the electrical signals generated by these electrodes, and they faithfully relay this information to the higher centers. This is how actually the cochlear implant works. And now what exactly are the indications? Who are supposed to get these implants. So, there are broad indications. Since it is a very expensive proposition, these indications, for example, children under the age of 6, even though cochlear implant can be implanted in any age, but we are holding this criteria as sacrosanct for the simple reason this is a very expensive equipment and it involves surgery. So, it is always better because the entire program, there is a state run program called state deafness control program, where they fund these implants to be performed or given to auditory challenged children. So, since this is going to be a free scheme funded by the government, we have a rigid set of criteria to go by who should receive an implant and who are not eligible to receive the implant. I repeat again, these are not surgical indications. These are indications for pertaining to the deafness control program. So, for example, the major indications are bilateral postlingual deafness. That is the first indication, wherein the deafness has begun after the child has learned to speak. I repeat again, postlingual deafness indicates deafness which has started after the child has learnt to speak. So, deafness after the age of 3. Commonly it occurs in meningitis. Then bilateral sensory neural hearing loss, which should be profound. The patient should not benefit by the use of hearing aid. Patient won't be able to hear and the patient will not derive any benefit by the use of hearing aid. So, bilateral profound sensory neural hearing loss. And if you do a speech audiometry, only 50% of the words heard by the patient could be repeated. So, that is another criteria. And last criteria is one thing which I keep stressing. This is not a rigid one. Children under the age of 6, this criteria has been included only by our government programs, so that beneficiaries should be targeted. Any program should target towards a beneficiary. So, children under the age of 6 is actually a criteria which has been incorporated among the indications to ensure that the government funded program reaches the target audience, and government resources, taxpayers money should not be wasted, because the entire program per se is very expensive. So, children under the age of 6 is actually the indication for deafness control program and not a surgical indication. Surgical indication per se are the top 3, and the last one, you can do cochlear implant at any age. Technically speaking, even an old man can have a cochlear implant done. That is as far as the indication is concerned. Let us go to contraindications. So, which of these patients who won't benefit by these implants? So, what are they? Who are they rather? Eighth nerve lesion or brainstem lesion. If the nerve per se, auditory nerve per se is involved, is totally degenerated. So, there is no point in attempting to stimulate a degenerated nerve. And if there is a brainstem lesion, again there is no point in doing an implant, because your impulse is not going to cross the brainstem area and get into the higher center. And then agenesis of cochlea. If the patient is going to have a congenital agenesis of cochlea, there is no way you can enter the cochlea with these electrodes and stimulate the vestibular cochlear nerve, because agenesis of cochlea will definitely have problems with the vestibular cochlear nerve. And then when there is active medullary infection. So, when there is active medullary infection, don't for heaven's sake put in a foreign body or namely the processor. So, when there is active medullary infection, if you put in the electrode, you will push the patient towards inner ear infection, even the patient may land up with meningitis. So, never operate on a child with active medullary infection. So, if the child is again having a eardrum perforation, this is again a contraindication for cochlear implant, because there is always a problem of potential infection to the medulla. And then last but not the least, if the child is mentally retarded, there is no point in attempting to make the child hear by performing such a costly procedure, because the mental growth of the child is not sufficient to cope up with the data which comes via the implant. So, child with mental retardation is always a contraindication for cochlear implant. So, let us go and look into the various evaluations, various tests you need to perform to find out whether the patient can be a candidate for cochlear implant or not. The first thing is you do a pure tone audiometry. The second thing is you do a speech audiometry to know whether the patient is not able to reproduce 50% of the spoken words or not. Then you use ABR. ABR is auditory brainstem response. This is actually done to test the integrity of the brainstem. The auditory brainstem response should be normal for you to implant on a child and make it work. Then autoacoustic emission, again to know whether the cochlear hair cells are functioning. If the autoacoustic emission shows that cochlear hair cells are not functioning, the candidate is a potential candidate for cochlear implant. Then HRCT can be done. HRCT can be done to know the architecture of the cochlea, So, the architecture of the cochlea can be identified only by performing HRCT. So, HRCT is ideal tool to know the anatomy of the cochlea. This will help us to place the electrodes appropriately. Let us go to the procedure. So, classically how we are going to perform the implant? The incision is placed in the post-oral sulcus. As you would do for a cortical mastodectomy. Then mastodectomy is done. First thing you do is you do a mastodectomy, open the mastod cavity and then widen the adductus, and then go ahead and do a posterior tympanotomy. These three things are a must. Incision is post-oral incision. The second thing, you do a mastodectomy, and then you go ahead and do a posterior tympanotomy or a facial recess approach. And then you create a small well in the mastotemporal area for you to place the receiver inside the well. So, the well should be drilled out with two small holes through which you can tie down the inner portion of the inner component of the incision. So, let us see how it works. So, this is actually the post-oral incision of William Wilde, and next you go ahead and do a mastodectomy. This is actually the adductus, and then here you have widened the adductus. This is the adductus. You see you have done a mastodectomy. This is the adductus, the arrow, blue arrow, and here this is actually the fossa incudis. My arrow is pointing towards the fossa incudis, and here this is the suprastructure of stapes. So, this is where you make a small opening here. This is where the facial nerve lies. This is the facial recess open, posterior tympanotomy. So, here the arrow points towards the round window niche. What you are seeing is a round window niche. So, you make a small opening in the round window like this by a micro drill, and then there is opening has been made. Through this opening you push the cochlear implant electrode. I repeat again, you perform a mastodectomy, identify the adductus, widen the adductus, and then identify the short process of incus, leave out a small bridge of bone below the short process of incus, keep drilling. You should be drilling between the chordotympanic nerve and the facial nerve, that is actually the angle, and if you keep drilling you will open into the medullary cavity via the facial recess approach, facial recess route. This is actually the posterior tympanotomy. The arrow points towards the round window niche. So, you make a small window in the round window niche, you see the small hole is being made, and through this small hole the implant can be, cochlear implant electrode, array of electrodes or a group of electrodes can be introduced. And then you create a small well in the temporal bone like this, and you create a small channel. Through this channel the electrode will pass. So, inside this well you keep the inner cochlear implant. This is actually a dummy implant, inner portion. This is used to assess the depth of the well, whether the depth of the well is sufficient or not. You just keep it and see. So, the entire implant should snugly fit into the well you make on the temporal bone. So, this well should be carefully drilled and you keep checking out using this dummy whether the depth of the well is sufficient or not, and through this channel the electrode will go. So, what happens, you keep this implant here, you see the electrode is going through the channel getting into the opening you have made in the round window niche, that is called cochleostomy. The opening you make in the round window niche to reach the interior of the cochlea is known as cochleostomy. So, now you see the electrode being pushed into the cochleostomy opening by this is actually the introducer which is used to push the electrode gently into the cochlea via the opening made known as the cochleostomy. So, this is actually the way the implant is performed. So, you see this implant is held in position by a proline thread, proline knot which is tied, which is anchored. Two small drill holes are made and the thread is crossed and tied across the implant, so that the implant will be held in position within the well and the skin will be redraped and sutured. So, when the outer portion of the implant is placed over the skin, this area is magnetic, the outer portion is also magnetic, it will stick, both will snugly stick to each other. And now, there is always a question, which ear should undergo the cochlear implant first. So, that again we need to answer. You do the implant, perform the cochlear implant always to the better hearing ear. So, the implant should be performed always to the better hearing ear. And then the next criteria is, you always perform the implant to the most recently damaged ear. So, it is always better to perform the implant to the most recently damaged ear. The third most important thing is, you should always choose a most radiologically favorable anatomy. So, if the patient is having a good mastoid aeration, well aerated mastoid on one side, you always choose that side, because you will be able to identify the vital structures and you will be able to do a better cochleostomy. If you are going to do a better cochleostomy, the position of the electrode also will be that much better and the patient will derive excellent benefit out of it. So, these are the three factors which decide which ear should undergo the implant first. Namely, you always attempt to implant on the better hearing ear, and then you always attempt to implant on the most recently deaf ear, and the third is, you always perform the implant on the most radiologically or radiographically favorable anatomy of the middle ear. So, this actually goes with the which ear to implant. Now, let us go to the complications. So, what exactly are the complications of cochlear implant? The common complications include bleeding, swelling in the operated area, infection which takes place in the implanted area, and then these children may have tinnitus, may have vertigo, they can have numbness around the ear because the sensory nerves will be avulsed in that area. These patients, since you are working in a triangle between the facial nerve and the chorotympanic nerve, these patients may have loss of taste, they may have dry mouth, and they may have facial nerve injury, which could be transient or which could be permanent. And these patients, some of them may have CSF leak and some of them may have meningitis. So, these are all the potential complications they can arise following cochlear implant. So, one thing you should remember is, the child is not going to immediately speak as soon as the implant is performed. So, there is something called switching on the implant. So, after the implant is successfully done, you do a switching on the table, you switch on the equipment and do a ABR study to ensure whether the impulse is reaching the brainstem or not. That can be done on the table, but after surgery you need to switch on the device. So, the entire switching on process of the device is actually a ceremonial process. You switch on the device on one day and the child will then start to hear the sounds. And let me warn you, the sound which is being heard is not going to be the sound which a normal ear is going to hear. For example, if you if I say water, you are hearing what I say as water and you perceive water in front of your eyes. But the child who is wearing a cochlear implant is not going to hear water as water. It is going to hear water as something else, some electronic gibberish it is going to hear. For the child to interpret this gibberish as water, the child needs to undergo auditory training. Are you able to understand what I am saying? If you use a hearing aid, if I say water, you are going to hear it as water and you are going to pronounce it as water. But whereas when you are implanting a child with cochlear implant, the child is not going to hear the same thing as you pronounce. So, suppose you say water, the child is not going to hear water as you hear the phonetics as. The child will be hearing something electronically gibberish. So, the child should be auditorily trained to identify these gibberish into meaningful words. So, that is where this auditory training is a must. So, that is done by a trained auditory teacher, trained speech therapist, trained therapist or language therapist who will sit by the child and keep training the child. So, how you train these auditory implanted children? You keep a bottle of water or a tumbler of water or a jug of water and you start saying water, you say this is water. So, the child should be able to repeat, the child should be able to say what exactly you mean by it. So, slowly the child will sync your lip reading as well as the sound which it manages to hear and then start to comprehend. So, this process of auditory rehabilitation following cochlear implant is a prolonged procedure, and a teacher, these teachers are known as audio verbal therapists. So, these teachers play a huge role in the success of your entire implant program. So, the AVT teachers, audio verbal AVT program as such, should be very robust before you start implanting children on large scale. So, you should have these facilities ready. You should have qualified teachers to perform this arduous task of teaching the child how to interpret the electronic gibberish into words which the child will be able to understand and the child will be able to repeat. So, that is the difference between a conventional hearing aid and a cochlear implant. The conventional hearing aid, the child is going to hear exactly what they are going to speak and the child is going to understand exactly what is being uttered. But the same thing is not true as far as cochlear implant is concerned, because it is directly going to stimulate the cochlear nerve. It is your external ear, middle ear and under ear functions are totally gone. Only your implant is going to take over the functions of all the three components of the ear. So, the child or a patient who has received the implant is not going to hear the sound in the same manner as you and me do. So, you just today, if you go with the idea that audio verbal therapy is a must after performance of the surgery, and they are more crucial than the surgical procedure itself, I will be very happy. So, this again is going to be a short notes only for you. So, if you have these basic ideas, if you know which category of patients need cochlear implant, if you know the indications for cochlear implant, if you know that there are two components to the implant, one is the outer and the inner components, and you have to do a posterior tympanotomy to insert the array of electrodes again. If you know all these things, I think you will be able to write a good short notes.